more advanced wounds, all right? I want to talk about how to treat them. And are there differences in procedures from center to center, practitioner to practitioner, and wound to wound? How do you begin to sort all this out? Anyone want to jump in on this one? How do you sort out a wound? I'm looking at this wound. How do I treat this?
Well, first and foremost, you have to do a complete history and physical examination,
Okay.
head to toe. You have to make certain that you're looking at every aspect of their medical care, what their underlying comorbidities are, et cetera. Very often we can use a checklist for that to at least guide us in the right direction so we don't miss anything. We're making certain that their vascularity is appropriate, whether or not they have problems orthopedically, neurologically, neuropathy, et cetera. And then once we make a diagnosis, then we can go down a pathway utilizing appropriate evidence-based guidelines as they are known today, and sometimes they vary. And by using that evidence-based approach, we can hopefully get a positive result.
Are there acceptable different pathways for the same wound? It looks the same, you get the history, maybe it's subtly different in history. Are there different ways to get to the same end? And are they acceptable going in two different directions?
The answer is, again, it depends.
I knew that was the answer. I knew this.
So as an example, you may have a patient who you think has a diabetic foot ulcer who's not getting better with appropriate therapy, offloading and debridement and moist wound healing. And you realize when you take a biopsy that they have a squamous cell cancer, or maybe they have a vasculitis.
Well, there's a difference.
Yeah. So you have to be able to have that knowledge base and have that flexibility and understand what the evidence is telling you to be able to make those decisions.
And that's another kernel that's come out here which never occurred to me, but should have, which is if you're doing everything right and it's not getting better, look for what's wrong. Maybe it's not what you thought, because there's something other, a different pathology.
So I had a mentor, Robert Warner, who unfortunately passed away, really an iconic figure in our field. And he had a mantra. He said, if the wound is not getting better within 4 weeks, start over because you've missed something.
Okay. Now, by the way, that's amazing. I have a partner in the ICU who says if the patient isn't diagnosed in 2 weeks, you're in trouble. It's similar. You got a real problem. If a patient goes to an emergency room for wound care, as opposed to a wound care center for wound care, and I'm assuming there are more emergency rooms, in fact I know this, than there are wound care centers. Is there a difference in the kind of treatment this patient's going to get?
I mean, I would say yes. But first of all, I would say that in the emergency department level, and you all can speak to this more than I can, I am not a pediatrist, I'm an orthopedic surgeon, so we
like them too.
We tend to defer these to our pediatry colleagues as well. But you know, oftentimes, as you know, as a physician, the ED is kind of like a sorting point. You know,
Sure.
your ED physician tries to figure out what's going on with the individual and then does a consultation. So do you even get definitive treatment, or are you even placed on the right track to definitive treatment at the emergency department level? You all can answer this better than I can, but I would suspect possibly not.
With all due respect to emergency room physicians, they've got an impossible job. They've got someone with the wound over here, someone with crushing chest pain over there, somebody in DKA and septic shock over there, and they've got to have 8 arms. They've got to be an octopus.
Remember, too, the ED physician is not going to develop a relationship with this patient. You know,
One hopes
it's
not.
a one and done. It's a one and done scenario. Secondly, they're not looking at the patient holistically. They're focusing in on that problem at the time. So very often they wind up leaving with an antibiotic that they may not even need, and referred to an appropriate specialist, hopefully.
Or maybe the outpatient-based hospital or hospital-based outpatient wound care center that happens to be down the hall.
Nudge, nudge, wink, wink.
And we also have the confounding factor that if you do have an individual who is seeking the definitive treatment over and over in the emergency department, that individual's probably not doing what they need to be doing to properly heal their wound.
Okay, let me ask a softball question. I'll give this one to you. It's 2 out, the bottom of the 9th. This is really softball. And you have a choice. Analogy, grant me this one. For going to a wound clinic or an ER or an ED for the treatment of your wound, what do you choose?
Knowing what I know, I'm going to a wound clinic.
He swings and the ball is heading over the wall. Yeah, I mean, it's obvious, right? You
Right.
do want to go there.
But there's something to keep in mind. The vast number of people who have wounds that require treatment don't end up in wound care centers. They end up in primary care doctors' offices. They wind up in a whole plethora of other specialty offices and not necessarily a wound care center.
Is that a consequence of not being any wound care centers, or because they're going to the wrong place, or because there's a lot of places you can get good wound care?
Or they don't even know what
Right.
a wound care center
They
is.
don't, but very often the driver is cost. Particularly if they're in a managed care plan or they're in some scenario where that entry point, that gatekeeper makes that decision.
Got it.
Then very, very often that gatekeeper will hold on to that patient for a period of time.